Okay, so I'm going to talk to you guys about ACL tears and meniscus tears, two things that really commonly come hand in hand. So I'm a sports medicine and shoulder surgeon. I'm the head team physician for St. Joseph's University, as well as our professional ultimate disc team, the Philadelphia Phoenix. So I have no relevant disclosures for this talk. So the learning objectives are to understand the risk factors for ACL tears, recognize the risk of further injury after ACL injury, and understand when to seek more immediate care. So anterior cruciate ligament or ACL tears are very common. About 200,000 surgeries for the ACL are performed in the United States every year. So these are very, very common injuries. They are most commonly associated with sporting activity, but they can occur from falls and just traumatic events. So the whole point of the ACL, it's one of the four major ligaments in the knee. A ligament basically connects bone to bone. So as you see in that drawing there in the front, you see the kneecap in the front, and you see ligaments on the outside, on the inside, and then there are two in the center. They're called the cruciate ligaments because they cross like a cross. And so those are the anterior and posterior cruciate ligaments. So your ACL is the one that attaches from the back to the front of your tibia, and it prevents your tibia or your shin bone from moving forward relative to your femur or your thigh bone. The posterior cruciate ligament prevents that same shin bone or tibia from moving backwards or posteriorly relative to your femur. A common way you'd injure that ligament is from a dashboard injury. If you were to get into a car accident and the front of your tibia hit the dashboard. And then the medial and the lateral collateral ligament prevent excessive valgus or varus motion, and those motions are pictured here. You see in the top picture the rugby player with that very dramatic valgus knee motion, which is basically a knock-knee motion. And that type of motion could tear your MCL or your medial collateral ligament. And the motion here of this guy pushing from inward to outward on this patient's knee could create an injury to her lateral collateral ligament. So for ACL tears, most of ACL tears result from what we call non-contact injuries. That means basically you're running and you decelerate very quickly, you land from a jump, you cut or pivot to make a change in direction. Those are what we call non-contact injury mechanisms. They are the most common way that you would tear your ACL. And in fact, 80% of ACL tears occur from non-contact injury mechanisms. Commonly, they result in early swelling, or what we call an effusion, which is swelling within your joint, but not necessarily so. I have seen some ACL tears with very minimal swelling. And very often patients will say they either heard or felt a pop in their knee, or someone around them heard or felt a pop, happen. And so when you take that history, you say a patient comes to you, they say, you know what, I was cutting in a soccer game. I shifted, I felt a pop, and then my knee swelled. 70% of those patients that describe that history are going to actually have an ACL tear. And we know that even before we examine them or get an MRI. So it's very common. Obviously, trauma is another way that you could tear your ACL. So ACL injuries have certainly a much higher incidence in female athletes. One in 100 high school and up to 1 in 20 college female athletes will tear their ACL per varsity year of sport. And when you look at women as compared to their male counterparts in the exact same sports, they have a much higher risk in the equivalent sports. So if you take soccer, women have a 3.5 higher odds ratio of tearing their ACL. Basketball, it's 2.7. So women in general just have a much higher rate of tearing their ACL, even if they're playing the same sports. So why might this be? A lot of it has to do what we think is with anatomy. They may have what we call a smaller intercondylar notch size. So in that top right diagram, from B to B prime, that's the area within which the ACL ligament lies. And so if that's narrower, we think that that could contribute to tearing your ACL. Also, your diameter of your ACL. So if you're a smaller framed girl, you may have a thinner ACL as compared to a large male, and that may be a contributing factor. Something called the Q angle, or someone who just appears a little bit knock-kneed, like that picture in the top left, could result in increased risk. If you're basically quad dominant, or your quad strength relative to your hamstring strength is higher, that is a risk factor. And then we know that estrogen has an effect on laxity and may contribute to ACL injury risk. But the reality is the studies are all over the place, and we're not exactly quite sure how it fits in. The reality is ACL injuries, the risk factors are multifactorial. There's environmental risk factors. If you're a soccer player and you have long cleats on and your cleat gets stuck in the ground and you try to twist and your knee pivots around your foot, that's certainly a risk factor. It could be anatomic, as we explained above. Certainly hormones play a role. But what we think is the biggest risk factor is neuromuscular. If you look at those two girls in that bottom center picture, you see how the one girl on the right, when she's doing a single limb squat, her knee goes into a very knock-kneed position. It doesn't look well balanced. As opposed to the girl right next to her. So that neuromuscular control of, or control of your limb in space when you move, we think is the biggest factor. And in fact, it's the thing we can actually modify. So we can actually train athletes and patients in order to have better movement or better neuromuscular control when they are landing, cutting, pivoting, decelerating, etc. And it involves improving core stability, improving hip flexion, increasing hamstring recruitment, taking away that kind of knock-kneed position, taking away the foot pronation, or the kind of inward position of the foot when you're walking, running, standing. And so when you do those things and you do ACL injury prevention programs, which are extremely effective, you can take a patient from looking like the woman on the right, who looks like she's landing with a very stiff leg. She's not bending her hip or her knee a lot. Her knee is rotating inward. All of those are things that you can actually improve with good training. And same here. You can actually improve your single leg squat mechanics, and these do translate into better movement patterns when you're playing sports. So if you were to injure your knee, you felt maybe something shift, the first thing we're going to do beyond examining you is actually get an x-ray. X-rays actually can be extremely useful, and most orthopedic surgeons are going to want an x-ray even when patients come in knowing that, you know, they did something a little bit more than break a bone. And so you see this x-ray on the left here. That's called a Sagun fracture. Those can be very indicative of an ACL injury. And so that's something that gives us a great clue even without getting an MRI as to what's going on. And then some patients will actually tear their ACL in a unique way. The ligament itself will remain intact, but that bone that the ACL attaches to, which we call the tibial eminence, will break and will actually elevate up. And those patients certainly, we usually follow this up with an x-ray, with an MRI, I apologize. But the x-ray really gives us the majority of the story. Up till this point, I have not yet encountered a patient who had a tibial eminence fracture whose ligament was not intact. So typically in these patients, we end up fixing that fracture. It's in some ways a much easier and faster recovery. So MRI is typically something that we will get to definitively diagnose the injury, as well as to get the full extent of the nature of the injury in the knee. So what can MRIs tell you? MRIs can really tell you everything. There's a very characteristic bone bruise pattern, which is basically this white that you see in the bone where the red arrows are pointing. They're called pivot shift contusions. And so when you tear your ACL, the shin bone moves forward, and basically those 2 points that are bruised contact one another. And so when it moves back into space, you see that bone bruise in the back on the tibia and in the center on the femur. These often result in pain on the outside of the knee. So most patients who tear their ACL will mainly complain of pain on the lateral or outside aspect of their knee. The more severe the bone bruises tend to indicate a more severe injury with maybe a greater ligament injury and maybe extra meniscus or cartilage injury. And bone bruises typically by the radiologist will be described as fractures, and that often confuses patients. But these are truly just contusions or bone bruises. They are not fractures in the sense that you need to fix them with a plate or screws or anything like that. MRI will also give you greater information as it relates to that bony avulsion of the tibial eminence, and will also give you information on whether or not there is an associated meniscus or cartilage injury, or if there are other ligament injuries involved that could factor in when you're trying to treat these patients. MRIs will also show you that tibial eminence fracture as you see there. So what's really nice when you see this is you really can see that ligament quite nicely. And so you can really tell the patient, you know, hey, look, there's a really nice piece of bone. I can fix that bone back down into its bed, put it in its normal position, retension that ACL ligament, and that patient will do very well typically. And that can be done through very minimally invasive means. So now you have an ACL tear and COVID hits and you're stuck at home. You can't get surgery because elective surgeries have been canceled. And your biggest question is it okay to wait to have surgery? And so there are many questions that I would ask the patient in terms of whether or not it's okay to wait. The questions would be, are you unstable? Is your knee shifting on you? Are there more than one ligament involved? So is it a multi-ligament knee injury or what we would classify as a knee dislocation? Is your knee locked? Did something happen, a meniscus tear or a piece of bone break loose where you can't straighten your knee? And what types of meniscus tears and how bad are they? What are the meniscus tears that you have, or do you have no meniscus tears? And all of these factor in, and we'll go into that a little bit. And then again, the next question, right? Everyone's being active is can I go and be active, you know, in this nice weather, and will I do further damage to my knee? So the bottom line is if your knee is shifting or giving out on you, each episode that your knee shifts could result in a new or worsening meniscus tear and cartilage injury. So it is not completely benign to leave an ACL tear alone. If you are not shifting, it's not giving out on you, you don't have any meniscus tears at the time of the initial injury that were diagnosed, you are someone who could elect to wait and do some particular activities, which I'll touch on later, in order to not risk your knee shifting on you. So let's talk a little bit about the meniscus, because this is really where things get a little bit complex with ACL tears. So the menisci are really two C-shaped structures. They sit between the end of the femur and the top of the tibia, and they function basically as joint deepening structures. They function in stability of the knee joint, so they back up the ligaments and help stabilize the joint. And most importantly, they work in shock absorption. So I refer to the menisci as the protectors of the cartilage. The moment that your menisci start to tear, that is when your risk of arthritis or progressive cartilage degeneration starts to increase. So let's talk a little bit about meniscus tears. Let's look at that picture in the center. That picture basically is showing you that kind of interlaced network of black is the blood supply to the meniscus. And so what's important to note is that blood supply really only goes to about the outer 25 to 30% of the meniscus. And that's very important because if a meniscus tear occurs in a location where there's no blood supply that will get to it, it is not typically a meniscus tear that we can repair or stitch back together. And typically we will need to trim those. So that's very relevant, the repairability of the meniscus tear. So tear patterns can be horizontal, they can be vertical, they can have flaps, as you see in that diagram. They can be complex, meaning they're just shredded. And then they can be what we call radial or root tears, or you could have a bucket handle tear. And when we think about meniscus tears, the most important and the most potentially detrimental to the health of your knee joint, not only in the long term, but really in the short term, are these last three meniscus tears. So Let's look at this image here. So we have that kind of in the bottom left to show us the blood supply. So this is the top of your tibia. You see the meniscus laterally and medially. So this is the outline of your lateral meniscus. This is the outline of your medial meniscus. So again, they're C-shaped structures. They're thicker on the very perimeter, okay? And that's where they get a blood supply. And they thin out very much in that triangular fashion as they enter towards the center of the joint. So menisci, as we said, they work in shock absorption. So they have these fibers, those blue lines. We call those circumferential hoop stress fibers. And that's the orientation of those fibers. They're attached to the bone in the front and in the back. And so when you step down and the femur pushes into the top of the tibia, by those the fibers being attached to the bone in the front and the back is what prevents that meniscus from basically being extruded between the two bones. Or I like to tell my patients, it's like a peanut butter and jelly sandwich. If you squeeze those two pieces of bread together, the peanut butter and jelly will usually squeeze out. And so what prevents the peanut butter and jelly, or the meniscus in this instance, from squeezing out is those hoop fibers attached to the front and the back of the knee. So if you have the more typical type of meniscus tear, that's usually one which we call vertical longitudinal. You see that green bar there. That's typically how it looks from the top. And then when you look at that bottom left image, that's how it looks in cross section. So it's the perfect type of tear. It's right in that blood supply zone. It's very much repairable and it's easy to fix, okay? The worst type of tears you can have are these radial or root tears. And that really, the only difference is where exactly it occurs. The radial tear is the one that occurs a little bit further away from the exact bony attachment. And the root tear occurs when the actual root that attaches into bone pulls out of the bone. But they are both devastating because they essentially incapacitate the meniscus. It's as if you've removed the entire meniscus because you've cut all those circumferential hoop fibers basically at 90 degrees. So meniscus tears, even in the absence of an ACL injury, will typically cause effusion or swelling. They will cause tenderness along the joint line, and you can see in that bottom central picture the reference to the joint line. So if you have a medial or intermeniscus tear, you'll often have pain there. If you have a lateral meniscus tear, you'll have pain on the opposite joint line. They can cause mechanical complaints of catching or locking. Locking typically, hey, I go to move and then like my knee literally gets stuck and I have to kind of twist it out. Sometimes patients are able to unlock it and sometimes it is kind of permanently locked until we intervene with surgery. So if you look at this MRI here, you see on the left-hand side, that arrow, that white arrow is showing you that meniscal root attachment for the inner or medial meniscus in the back of the knee. So you can see that nice kind of black structure go all the way down and attach into the bone. And then when you see that right-handed picture, you see that detachment essentially, or that tear right at the root. And then you see what happens. You're seeing this entire meniscus by those white arrowheads is being extruded like peanut butter and jelly from between the bones. So again, this is a really severe type of meniscus injury. It can have really devastating consequences on your knee joint. Bucket handle tears are also tears that you want to get to quickly. These are typically repairable meniscus tears. They usually involve a large portion of your meniscus, and the longer you leave these alone, the less likely we are going to be able to repair them because they actually undergo what we call plastic deformation. So when they're in this displaced position here, like you see in this kind of picture on the left, you see that gray arrow there showing you that piece of meniscus that's flipped to the center of the knee. It flips literally like a bucket handle, and that's why we call it a bucket handle tear. And sometimes these will flip and stay flipped, and the patient won't be able to fully straighten their knee. And sometimes they flip over and then go back and flip over and go back, and the patient will complain of, you know, every once in a while I can't straighten my knee, and then it kind of falls back into position. And so those MRI images, those white arrows are again pointing at the medial meniscus that's flipped over. And again, this is something else that we want to get to quickly. Treatment in general for ACL tears, if you're not very active or you're sedentary or you enjoy things that don't involve any cutting or pivoting, and you're not having instability episodes, certainly you can brace your knee, you can do physical therapy, and you can certainly do very well. But surgery is really the mainstay of treatment, most importantly for patients who have multiple ligaments that are injured or knee dislocations. If they are active, athletic, they want to return back to cutting and pivoting sports. We are typically reconstructing those patients. And when I say reconstruction, what we do is we use tissue from either some other source within your own knee joint, the same knee that we're doing surgery on. We call that autograft. Patellar tendon, quadriceps tendon, and hamstring tendons are the most common grafts. And then allograft tissue or donor tissue is also an option, again, depending upon your age and your desired activity level. For meniscus tears, again, as we said, this top right-hand corner, you see a displaced bucket handle tear of the meniscus, which we can stitch back together. They tend to heal very well because most of those tear in the very periphery where there's a very good blood supply. Root tears can be repaired in very minimally invasive ways as well by basically stitching the meniscus and creating a bone tunnel and pulling it back down to the bone, as you see in that top left picture. Radial tears as well can be repaired. Again, as you can imagine, because you only get a blood supply to that outer 30%, they are certainly much higher biomechanically to get them to heal. But there's really great success, particularly in young patients, as well as patients who you're doing an ACL reconstruction at the same time. In general, when we repair a meniscus at the same time as an ACL reconstruction, because we're drilling tunnels into the bone to pass our graft or our tissue and fix it, that drilling of the bone introduces so much blood into the knee joint that's really a perfect environment for healing of the meniscus. So we typically get about a 90% or higher healing rate of meniscus tears when they're performed at the same time as ACL reconstruction. So what should you avoid if you're deciding to treat this conservatively? Deep squatting. So as you see that guy stretching there, that squat and that stretch could be the thing that does you in. Your knee could shift, your meniscus could pop. I've seen multiple patients, kind of women in their 40s or so who have a known ACL tear that they've treated conservatively and they've generally done well. And they did something, either squatted down to pick up their kids, they were cleaning something or trying to reach something, and they squatted up and popped. Their ACL was already torn and then they tore their meniscus. So deep squatting can be problematic, so better to avoid it. Avoid twisting, pivoting, and jumping types of sports, which are the typical ways your knee would shift on you again. What can you do is you can run. Running in a straight line on even ground is something that typically patients can enjoy without any instability episodes. It is not 100% true that you can do that without instability, but most can, so that's certainly something to potentially try. Using the elliptical machine, a stationary bicycle, or a regular bike will be okay. Most weightlifting is okay. And hiking. Hiking is okay, but I would avoid any steep terrain because if you're going up or down any sort of major hills or there's loose gravel, it could be problematic for you. So in conclusion, when should you seek more immediate care? You are currently having instability episodes. You know you've torn your ACL, but your knee keeps shifting on you. You can't do basic everyday things. You can't return to sports activities because your knee feels unstable. Often patients will say, I don't trust my knee. If you have a bucket handle meniscus tear, if you have a radial meniscus tear or a root tear, those are things that we really don't want to leave alone. We want to treat those because those can really have really tremendously negative consequences on your knee joint. And then in any ACL tear with an associated meniscus tear in a young patient. Young patients obviously have many years before we want them to ever see Dr. Courtney. And so we really want to preserve their joint. Most of what I do is joint preservation. We want to avoid joint replacement, whether it's in the shoulder or the knee. And so those patients we really do want to see sooner rather than later.